But what we'll do now is we're super excited to introduce Dr. George Rutherford, who is going to talk about emerging infectious disease, specifically Ebola, and preparedness. George is the co-chair of the Ebola Task Force for UCSF campus. He is a pediatrician. He is also the director of the Prevention and Public Health Group. He holds the Salvatore Pablo Lucia Professor, Endowed Chair of Preventative Medicine. He is the head of the Division of Infectious Disease Epidemiology, as well as the vice chair of the Department of Epidemiology and Biostatistics in the School of Medicine here at UCSF. He is also very active in the Global Health Sciences division. I'm probably leaving something out, but we are thrilled to have you here. Infectious disease and preparedness is a very important topic for all of us, and this content bridges to your next course in 245B, where you'll be focusing more on global health and also on advocacy and policy. One of your required readings was looking at nursing and whether nursing is prepared for disasters and emerging infectious disease, and the answer is no. No. And so really we want, this is a fabulous opportunity to apply population health principles. And so welcome, George, and thank you so much.
Sure. Thank you, Barbara. It's hard to get excited. When you say it's excited at 8 a.m., it's sort of hard to imagine. But let's see if I can amuse you at least with this story. So in Marburg, Germany, in 1967, there was an outbreak of an unknown hemorrhagic fever. It was also, within a week, it had also occurred in Belgrade, Yugoslavia, and in Frankfurt, West Germany. And it was a big deal. There were 31 cases eventually, and 7 deaths, and it was eventually linked to exposure. This was in laboratories. These were in medical laboratories to primates that had been African green monkeys that had been imported from Uganda, or the tissues of these monkeys. So this was called Marburg hemorrhagic fever, a sort of homage to the German city in which it was first discovered. And it was found to be part of a new family of viruses called the Filoviruses. So for those of you who remember your Latin, philus means thread. So this is a thread-like virus. The reservoir is felt to be a cave-dwelling fruit bat, which is this guy over here. And this is why it's like a seriously bad idea to go cave exploring in Uganda. There is probably aerosol transmission from bats to humans. Bats are like cats. They lick each other. When the humidity goes up in caves, it's because of bat saliva, which is why you have to have rabies vaccine if you're going to do this. They also have lots of rabies. And the primates are incidental hosts. And the cases of Marburg virus that have occurred in Africa since 1967 have been primarily in miners who've been in caves mining whatever, typically guano. So fast forward into about 9 years later, and another hemorrhagic fever appeared in Zaire at a mission hospital in Yambuku, which is up in the north of the country, which is near the Ebola River, which is a tributary of the Congo River. This was spread nosocomial. This is total nosocomial transmission after the first case occurred through contaminated needles and syringes and then by traditional burial practices. And you'll hear me come back to traditional burial practices, which is a kind of cultural phenomenon that goes on in many parts of Africa. Basically, the idea is that when you're launching someone into the afterlife, they need to be as clean as possible. Now, that means draining the blood. If they're pregnant, they evacuate the pregnancy. They basically disimpact the bowels. It's a massive undertaking. So they say, in car wash terms, they would detail the body. So there's a lot of exposure that goes on there. This was closely followed by another outbreak in southern Sudan with 254 cases, and the case fatality rates were very high. It was 88% in Zaire and 53% in Sudan. That assumes you found all the cases. And this was classified as another new filovirus called Ebola virus. Now, there have been a number of Ebola virus outbreaks or filovirus outbreaks over the succeeding 20, 30 years, 40 years, whatever it is. there are, as you see from the numbers here, these typically are relatively small, and the numbers of cases are in the hundreds. I was involved when I was the chief of infectious diseases for the state of California with Ebola restin virus, which is a disease only of monkeys, of certain types of monkeys. These were Philippine crab-eating monkeys. And there were a number of cases in Reston, Virginia, right next to the CIA headquarters. This is just where all the storage goes on for Dulles Airport. And these were animals that had been imported and they were going to be redistributed. And they had this hemorrhagic fever that spread from animal to animal through the cages. We actually found, we did a serosurvey. This is a fascinating little project. A serosurvey of all people who handled monkeys in California. So it was everything from, as you would imagine, medical research facilities, but it was circuses and the movies and television and people who had them as pets. And we found 2 people who were positive for Ebola restin, who were both animal handlers at a university. And then what do you tell them? So what are we supposed to do now? After you give them this cheery news. Well, he said, don't donate blood, which is probably the worst advice we could give because you probably want their blood, or at least their antibodies. But going forward, this is now, you can see some couple of Marburgs, and then a series of Ebola outbreaks, DRC's Democratic Republic of the Congo, formerly Zaire. But you can see how this is utterly eclipsed by the current outbreak in West Africa. There previously had only been a single isolate in West Africa, which was the Tai forest strain of this, which is in Ivory Coast. And Cote d'Ivoire is right next to Liberia. I'll show you some maps. You got to kind of visualize the geography. So overall, the hemorrhagic fever viruses is like saying rash viruses, okay? It's just, they're all tied together by a symptom complex, and they're not necessarily virologically related. So the ones we've worked with a lot are arenoviridae, like Lassa fever, which occurs in northern Nigeria. The Bunyaviridae, the most common that we deal with is the Sinombre virus, which causes hantavirus pulmonary syndrome. That's a disease that occurs in the Great Basin and on the east slope of the Sierra. Then the Filoviridae, the flaviviruses, and West Nile is now completely endemic in the U.S., with the exception of a handful of states like Alaska. And that was a total importation. That came in a cargo hold on a plane from the Middle East, actually from the Near East. And the first cases were in Queens County, New York, which is where Kennedy Airport is. First cases in California were in Inglewood, which is across the freeway from LAX. So you get an idea how these things can fly around pretty well. Dengue is also making a big comeback and is marching up the Caribbean. It's become endemic in parts of Mexico, and there have been outbreaks in the Keys, Florida Keys, and in southern Texas. And then there are a couple of paramyxoviridae, which are kind of distantly related to measles, that are occurring, that have been problems in Australia. But these are all kind of cause the same sorts of symptoms. They're all bad, right? Okay. So the filoviruses are RNA, single-stranded RNA viruses. There are these different Ebola species, subspecies, and then Marburg. This is a fairly fragile virus, and it's disrupted. The envelopes can be disrupted by chlorine and soap and a variety of other things. But it's also a relatively large virus with 40,000 base pairs, and you expect just on chance alone there to be 2 mutations per cycle, per replication cycle. So when people ask you, is this mutating, the answer is, yeah, it is. It's mutating. Now, whether it's for the good or the bad is another issue. And this just gives you an idea of kind of what it looks like. Again, it looks like a thread with that's basically an enveloped strand of RNA. Now, since this is a preventive, this course is focused on prevention, I thought I'd talk a little bit about risk factors for Ebola. Your risk factors for Ebola, so leaving out the primary cases, okay, the ones that get it from animals. So don't pet bats. That's my advice. The Risk factors for Ebola are contact with body fluids from a symptomatic infected patient. While this isn't completely 100,000% true, most people, almost everybody with Ebola no one with Ebola is infectious until they become symptomatic. There's not like measles, there's this 3-day prodrome, as we saw in Disneyland, where people can walk around and sort of not feel perfectly well but don't really have a characterizable rash. This, sort of symptoms and infectivity hit at the same time with these viruses. So you have contact with body fluids from an infectious person. This can be in a community, so if you're providing care for someone at home or in a hospital setting. The second one is participation in these traditional burial practices, and there have been, this is a big amplifying event in epidemiology. There is one outbreak within this larger outbreak of Ebola where something like 17 people became infected when they helped prepare the body of a traditional healer for burial. And then the real primary thing is contact with bats. Now, I'm probably not going to talk a ton more about bats, but I can talk about bats for hours if you want to know. So just bats are, they're wild animals, right? And one of the interesting kind of ecological features that may have caused this is that there was a sort of large-scale deforestation of the Atlantic forest, coastal forest in these countries. And I'll show you a map in a second. You'll get an idea what I'm talking about. And they were replaced with palm oil plantations. Palm oil have these little palm fruits that hang on. This is not like in India with the dates. These are different. Palm oil, they're all full of oil, like dende oil in Brazil. And each one of these little fruits has a fruit bat hanging on it, practically, right? This is what these guys eat. And they drop them. They're not particularly fastidious, and they drop them all over the ground. And the index case in this outbreak was a 2-year-old, and the thought was that the child picked up a piece of fruit that the bat had been snacking on. So it's as simple as that. Now, the other thing, since you're sitting here and we're talking about prevention, there's no such thing as a bat with a broken wing, okay? Repeat after me. There's no such thing. There's no such thing as, so bat rescue missions, crazy, right? If they have a broken wing, they're hemiplegic from rabies. So do not touch it, do not touch it, do not do anything. Okay, the community level risk factors are burial practices, this traditional burial practices, and the structural things that cause this are really lack of isolation beds and really lack of a healthcare system. These countries have all, especially Sierra Leone and Liberia, have emerged from 10 plus years of civil war with complete disruption of the infrastructure and disruption of the supply of healthcare workers. And the other thing is that there's really no money to buy personal protective equipment, which you wouldn't have recognized probably on the first case. These things look surprisingly, until they turn really sour, look surprisingly a lot like common diseases like malaria and typhoid. Yes?
I have a question. From the bat perspective, is it ingestion or is it inhalation or both? I mean, as far as do they cook bat to make a stew?
Yeah, actually, and that's probably what was behind the original so we call, people have all these funny words like bush meat and stuff like that. This is a protein source. I mean, we call it hunting, but when they do it, it's called something weird and kind of culturally inappropriate and stuff. This is really the major protein source for a lot of these people living out in the countryside. You don't get a lot of protein eating fruit that falls out of trees. So this is a real big source of protein. And yes, they're hunted with nets. So you put nets across something and drive them into it. But that's not thought to be part of this. Although you probably can get it by ingesting the bat, you probably just only have to handle because they secrete a lot of this stuff in their saliva. Okay, so the primary transmission is likely from fruit bats, and the secondary transmission is percutaneous or mucous membrane contact with blood or body fluids or unsterilized medical instruments, which is a huge amplifier in the early outbreaks of Ebola in Zaire. The burial preparations I mentioned. The people who are at highest risk are healthcare workers and close contacts. Women are more at risk than men because they're more likely to adopt these roles. The transmission's only from symptomatic people, 99% of the time. but it's probably also transmissible from primates, as we saw with Ebola reston, and pigs. This gives you an idea of the geographic range. With the this is the Democratic Republic of Congo. This is the original sites for these outbreaks, and you can see that it spills over into Sudan. This is actually South Sudan now, and Uganda, and then out here to the west. This was the original Taï forest thing in Côte d'Ivoire. Okay, how many of you been to Africa? So who's flown from Europe to South Africa? How long did it take? 12 and a half hours. It is huge. It takes forever, right? 12 and a half hours you could be in Rio de Janeiro here from the West Coast. So the size of the continent is immense, and they talk about, well, it's just next door. Well, it's like we say, well, Montana's just next door. You know, it's like that far, right? So you have to get a feel for this, for the geography. This isolate in South Africa was a tourist who was returning after doing cave exploring. Not a good idea. These are some of the helpful WHO and CDC messages. You know, that it's about trying to be clear on this point of symptoms equals infectivity. And these are some of the other public service things about how you can't get this. Now, what we do know is that with any kind of reasonable isolation precautions, the chances of it being transmitted are lessened. In epidemiology, there's a concept that has to do with how many people somebody who's an index case can infect, typically would infect. Right? It's called R sub 0, or the British are fond of saying R naught. So it's the basic reproductive number. So for measles, you guys know this concept? Have you heard about this before? So what is it for measles, would you say? Since you nodded your head up and down.
I've just heard of the concept.
What do you know? What do you think for measles?
I think yes, the percentage
12?
12.
No, it's more like 12. It's 15, I would have said. But, you know, basically if the R naught is above 1, there'll be epidemic spread. It'll continue to double. If the R naught's below 1, it'll dwindle because you're not replacing each case with a new case, right? So if they're hospitalized, these are models, the R naught, the number of extra cases you'll get, is 0.12. So that means you need, for every 8 people hospitalized, there'll be 1 nosocomial transmission. It's not much different for people who are kept at home with reasonable infection control precautions. In there, it's something like 1 in 6, or 1 in, almost approaching 1 in 5. So for every 5 people who are kept at home with reasonable infection control, in place, there'll be 5 additional cases. Or for every 5, there'll be 1 additional case. So you can see how that will sort of dwindle out over time. If they're at home with no effective isolation, the R naught is closer to 2, which means that you get 1 case, then you get 2 cases, then you get 4 cases, then you get 8 cases. It'll just continue to multiply. Now, what are the signs and symptoms? Fever is the most common sign and symptom. There are severe headaches. And actually the reason, this is a site diagnosis, these hemorrhagic fevers, the filoviruses, because they get hiccups. And the Médecines Sans Frontières, the Doctors Without Borders, person who first saw these patients was remarked on hiccups, and somebody said, oh, it's got to be a filovirus infection, right? So it's a really kind of pathognomonic sign. There are myalgias and weakness, vomiting and diarrhea, abdominal pain, and about half will develop the hemorrhagic manifestations, which means they'll start vomiting blood, having bloody diarrhea, and start bleeding from their gums. And this is an example of what that looks like. The clinical phases, in the first 3 days, there is really debilitating fever, malaise, headaches, body aches. And then there's for the next week, there's really basically an abdominal phase, which when people were treated in Europe, there was actually a long case report in the New England Journal about a patient treated in Germany. And these patients have an ileus. Their bowel becomes paralyzed. which brings into question, like, how are you going to orally rehydrate these people, which is what some people have said they want to do. And they have epigastric pain, nausea, vomiting, and diarrhea, and with a whole bunch of other things. And then they can either, then they'll move into a kind of a late phase around 7 days, 7+ days into it, especially if they start developing bleeding. Okay? And this just gives you an idea of, in Guinea, which is one of the 3 countries that's affected. Again, I'll show you a map in a second. This gives you an idea of what the symptoms were when they presented. Fever, fatigue, diarrhea, headache, vomiting, anorexia. So they're sort of in the second phase of illness when it's recognized. Okay, systolic blood pressure 125. Okay, so they haven't entered the shock phase yet. They had from hospital admissions, interval from onset of symptoms to hospital admission is around 5 days, and here the from onset of symptoms to death was 8 days. Okay. Now, there are a variety of risk factors for mortality. So in this series, again, the same series, 43% died. They were in the hospital for 8 days on average. And any hemorrhage was 50%, right? So this, not everybody with hemorrhagic fever has hemorrhages, okay? But they all have fever. There were relatively small numbers of people who had renal failure and seizures. Now, you'll hear about this magic 21 days that everybody talks about the incubation period, the outside edge of the incubation period being 21 days. And so if you go to West Africa and come back, you have to go into quarantine, sort of, for 21 days, depending on your degree of contact. The 21 days really represents a 95% confidence interval, the upper bound. So it's one thing when you have 2 people and you shouldn't say 21 days. It's quite another thing when you have 10,000 people, because there's some that are going to have symptoms beyond that. But this is what the curve looks like from exposure to onset of symptoms, with a peak being around 4, 5, 6 days. The other thing to realize is that when WHO declares a country Ebola-free, and they declared 5 countries Ebola-free, and they're working on the 6th. The 5 they declared Ebola-free are Nigeria, Mali, Senegal, Spain, and the United States. And that's based on not having any secondary cases within 42 days to maximal incubation periods. The risk factors for death are young age or old age, or sort of middle age or kind of late young age. At pregnancy, there's a nurse midwife at Davis who spent a long time up country in Sierra Leone trying to do basic obstetrical care, which was just a total mess. If you're exposed to a large inoculum, like you're stuck with a hollow bore needle as opposed to a suture needle, and then exposure to corpses or patients with advanced disease, the viremia just keeps going. So that the people with most advanced disease are the most viremic, they're the most infectious. People who have short incubation periods, again, suggesting large inoculations. Rapid progression of symptoms. If they develop liver failure, that's a bad sign. And if they start having GI bleeding, that's a bad sign. This is from the same series and from Guinea. If you look at survivors and non-survivors, again, this is all of 37 patients. The things that were significant were the viral load at admission. Non-survivors, see, they had 20-fold higher viral loads. So that means they had 20 times greater concentration of virus in their serum. And the proportion that had more than 100,000 copies was a quarter versus none. And those were that's sort of the big, and the age. So it's younger versus older. Okay. And this just is another series that sort of lays this out a little bit more closely. If you look at the case fatality rate by age, if they're under 21 to 45, and over 45, it increases both with age, and then the viral load also is a predictor. Higher viral load is also a predictor of case fatality rate. So as you know from HIV, a viral load of an HIV patient, it's walking in off the street, might be something like 10 to the 5th. It'd be 100,000. That would get everybody's serious attention. Here we're talking about 10 million. Okay, so there's much more virus here, kind of like on the order with hepatitis B. Now, how do we prevent transmission? There's no vaccine available. There are a couple out in the field being tried now in phase 2B trials. There was, interestingly, when they went back and resurveyed populations in Zaire years after these outbreaks, they found that about 12% of people with no history of clinical disease had antibody. So there suggests there's some subclinical or modestly clinically apparent disease that goes on. But the idea about preventing transmission here, once this starts, again, stay away from bats, but once this starts, it's about moving people into isolation rapidly to reduce the number of secondary cases, and then also the safe burial practices. There's really no specific treatment. It's all supportive care. There have been some, basically kind of made up stuff from ICU land around ACE inhibitors and statins about sort of trying to stabilize endothelia. There are a variety of antiviral drugs under study. The one you probably heard of the most is something called ZMapp, which is basically just antibodies. It's 4 different antibodies that have been sort of harvested from tobacco plants in this kind of great feat of molecular biology, although it's a problem because tobacco plants grow very slowly. So they've tried to move that into yeast cultures so you can do it like you brew beer. You get much more rapid turnover. And that's been used a number of times in the US, and about half the people live and about half the people die. So it's they kind of get it as last rites. And sometimes it seems to work and sometimes it didn't, but there's absolutely no randomized controlled trials with this. They're trying it now that they're able to produce enough of it, they're trying it now in West Africa to see what's going on. There was a lot of excitement around lamivudine, which is an HIV drug. It's also used for hepatitis B. It's what's called 3TC, if you've heard, if you sort of trip these abbreviations, trip off your tongue. There's a report from Liberia about a guy who, at a district hospital, he just sort of threw his hands up. He had nothing there. The only antiviral they had on the shelf was lamivudine for HIV patients. He started to give it and had, good results. Now, why would this work? This is a reverse transcriptase inhibitor. There's no reverse transcriptase in filoviruses, so who knows? But we've been trying to track down all the HIV-infected patients in West Africa who got Ebola virus, and then try and sort them by who was on antiretroviral therapy to start with versus who wasn't, and whether there's differential survival. It's like, the record keeping is not, it's not particularly conducive to studies like that, but we're still looking. Now, this current outbreak. So the first case, as I said, was in a 2-year-old in rural Guinea, and that gradually spread to the capital city of Conakry, and as well as across the border to Liberia and Sierra Leone. And as I said, there was an early case in a traditional healer in Sierra Leone that led to 14 genetically linked cases. Now here's the geography. Okay, so here's the first question. How many countries have the word Guinea in their name? So let's start over here. So go ahead, what's the first one you can think of? French Guinea, yeah. So we don't say that anymore. It's called Republic of Guinea.
Okay.
But that's the one we're talking about here. Okay, what's another Guinea? Papua New Guinea, other side of the world. Okay, how about another one? Sorry? Yeah, well, that's Papua New Guinea. Yeah. How about another one? So it's Portuguese Guinea, which is called Guinea-Bissau, which is up here, right? And then the only Spanish-speaking country in Africa. We have all these students who want to go to Africa, but they speak Spanish. And I say, there's only one country in Africa where they speak Spanish, which is Equatorial Guinea. That's a $500 Jeopardy question, in case anybody asks you. We're talking about the former French Guinea, which is called Republic of Guinea these days. And this is it here. And this Conakry is the capital on the coast. And the first cases were reported from Guécadou. And this little kind of parrot speak here, this is where the first cases were occurring. And you can see how it's really close to where these countries come together. and there was transmission across the borders. This country is all broken up by mountains and stuff, Guinea. So it's, even today, there's not transmission up here in the northern part. So the current outbreak there have been 23,948 cases diagnosed, and there have been about a little, around 40% of them have died. These are the cases that we know about. These are the deaths we know about. Okay? As you might imagine, there's lots of chaos and there's lots of underreporting of disease. There have been 20 cases in Nigeria, which was a remarkable feat of public health, and I'll talk about that in a second. There are 9 cases in Europe, which involved one transmission in Europe to a healthcare worker and to a nurse in Spain. The others were people who were evacuated back. In the U.S., there have been 5 evacuees who were brought specifically for care. 2 people who were diagnosed once they returned. They came back asymptomatic and developed disease. One was in New York and one was in Dallas. And there have been 2 nosocomial transmissions, both in Dallas, to nurses. In Senegal, there was a single imported case that didn't spread. And then in Mali, there have been 7 cases plus 1 nosocomial transmission. Just so you know, this is Mali up here. So this touches it. This is all contiguous. And over here, this is where Nigeria is. So this was a flight. Somebody flew out. Okay? And this is looking at the cumulative totals. So these things always go up because they accumulate, right? And it's, there is, you can see some flattening here of new cases in Guinea and some flattening here, but Sierra Leone's still going on. If you look back here, if you look at the cases in the last 21 days, Liberia has really made remarkable strides forward. There were only 10 cases. There have only been 10 cases in the last 21 days. In Guinea, it's about 150. In Sierra Leone, there are 235 reported cases. There was an article on the front page of the New York Times on Sunday about a group of fishermen who'd come back from fishing, and several of them had disease when they hit the wharf, and then they get spread, and there's now a new outbreak traced back to that. Now, this is what the map looks like. Again, Mali, Guinea-Bissau, the Portuguese Guinea, Cote d'Ivoire here, Liberia, Sierra Leone. This is Monrovia, the capital of Liberia. This is here is Freetown, the capital of Sierra Leone, and up here is Conakry, the capital of Guinea, the big cities, right? And it's a little hard to see that. I'll show you better, but this just gives you a complete idea of the density here of disease. Right? Up here you see there's no disease, right? And this is because this country's sort of broken up. And there's been very little spread into southern Liberia as well. Now this is where the cases have occurred. This is the number of days since the last confirmed case. And you can see the greater than 42, which represents the 2 generations of 2 incubation periods. Almost all of Liberia has been disease-free for a while. This is Monrovia. Montserrado County is where Monrovia is. And that still has new cases, a few new cases coming in. But up here in Sierra Leone, you can see the epidemic's still raging. This just shows this graphically. Guinea's always had fewer cases. It's a much lower level epidemic. It would still be the largest Ebola epidemic ever recorded. Just so it's relatively small, only in comparison to these others. This is what's happened in Liberia. Don't worry about these colors. This is just how they count them. And in Sierra Leone, there's still ongoing transmission, and there are probably more cases that are going to be recognized back in here. Now, how do we know this is going down in Liberia? This is kind of an interesting question, because everybody wants it to go down. Everybody wants to have happy talk. Everybody wants to say that this is going away and is getting better. If you look at the place that most patients are treated are called Ebola treatment units, ETUs. And this is these are the numbers of admissions to ETUs in Montserrado County, again, where Monrovia is in Liberia from June through October. And you can see that they were, that first of all, the number of non-cases, people who were, they basically had their infection ruled out, is going down. and that the overall number of confirmed cases was going down. So that's one bit of evidence. This is another bit of evidence. There are basically burial squads that go out and pick up bodies from people who died before getting to the hospital, and the number of bodies collected has gone down. Look at this y-axis, though. You know, this is like 200. This is like good news. They only found 200 people dead on the ground of Ebola. So, okay, and this is another thing, is they looked at capacity, ETU bed capacity. Again, remember that thing about the basic reproductive number, the R naught, where it was 0.18 if it was in a, or sorry, 0.12 if it was in a regular hospital. This is building the capacity. And so you can see as this capacity has gone up, the number of patients in these different, this is Montserrano County again, the number of patients newly diagnosed has gone down. Now, the burden on healthcare workers is extreme in these kinds of outbreaks because they're the ones who are going to get sick first. In the early Zairian, Congolese outbreaks, 80% of the patients were healthcare workers. Here it's less so, but it's still a substantial burden, and there are not enough healthcare workers to start with in these countries because they've left or because they didn't get educated or whatever. There have been 837 healthcare workers infected, and about 60% of them have died, including all the infectious disease specialists in Liberia and Sierra Leone, the head of the big emergency department in Lagos in Nigeria, where this patient from Liberia went. And so that's a problem. The other problem is that they close hospitals, right? And so that people who shouldn't be dying of things like malaria, like obstructed labor in pregnancy, like typhoid, are dying. So there's a huge secondary toll from this as well. This is what happened in Nigeria. I mentioned this before. There was a single case that came in that was somebody who'd flown in from Liberia. And then there was all this sort of additional transmission from probably about 3 or 4 waves of transmission. It spread from from Lagos to Port Harcourt. That's kind of like spreading from downtown Los Angeles to Long Beach. Yeah. And but the Nigerian Ministry of Health, which had had a ton of training around polio eradication and really knew how to do contact tracing, I think did a remarkable job in limiting this. This could have been basically, you know, if it had gotten into Nigeria, it would have spread all over the world. Yeah, you had a question?
I saw that for healthcare workers, the fatality rate was 60%.
Yeah.
I was wondering what the idea is on why it's higher than 40%, which is the general.
Yeah. Well, you probably have, first of all, you probably have a better count on the deaths. Don't believe all the numbers. It's just take them as sort of a feel for a minimal kind of estimate. And they probably have larger exposures too, right? So if you're taking with somebody they're vomiting blood on you, taking care of someone they're vomiting blood on you, and you don't have the right kind of stuff on, you know, you're pretty much going to get infected, pretty much. Although, you know, there is this kind of question about how infectious is this really? You know, we treat it as like, you know, the Black Plague and the Black Death in 1349. But this guy who came back from Liberia, who was hospitalized in Dallas, lived with his girlfriend for 5 days, slept in the same bed, and was, you know, went into the hospital, came back home, went back in, you know, and she didn't get infected. So it's, you know, who knows why, but you suspect that this is a little harder to get than people have said. Kind of the genomics of this are interesting. The index cases, the sort of the first wave of infections, seem to be related to a strain from a Congolese outbreak in 2004. Since the incubation period of this is not 11 years like HIV, this really probably represents migration of bats who shared the same strain in Zaire, again being lured by the promise of new food and kind of changing ecology. There was a single transmission event originally, and there's now spread into a couple of different viral lineages, which you can see here, one here and one up here. Okay, so how do we interrupt Ebola transmission? Well, the first thing you do is you have exhaustive case and contact finding. So here's a good question. This is an exam question. All right, so what's isolation mean? With a Mac, go ahead. Yeah, you, yeah. Sorry, I don't know any names. If I knew names, one person would get picked on the whole time.
Isolation.
So let me ask you something here. In your family, where are you in the birth order? You're the youngest. So I had a psychiatry class in medical school, and they were talking about family. And they said, how many of you are the oldest? It was everybody in the first 3 rows. How many of you are the middle children? It was everybody in the back 3 rows. And the youngest one in the sort of middle, right? So I was going to predict this, but just a little factoid for you there. You'll never remember what isolation and quarantine mean, but you'll remember that forever. Go ahead.
I would just say in general, taking an affected individual out of the population.
What's affected mean?
Infected.
Infected, yeah. Infectious, right. Right, so isolation is what you do to somebody who's infectious, right? And you take them out of the population, right? And then what's quarantine? So I'm not going to torture you because I'm just guessing you didn't take Latin. So who took Latin here? It's amazing. See? Good. What's quarantus mean? 40. That was an easy question, right? So quarantine refers to people who've been exposed but are not yet infectious, right? And the quarantus, the 40 days, was how long the Venetians made ships lie at anchor coming from the Ottoman Empire. No, actually coming from the Byzantine Empire, given the years. Before they would let them offload cargo, and it was twice the incubation period of plague, it turns out. So that's where the word quarantine comes from. It's about people who are exposed, who may develop infection, but who are not yet infectious. It was used heavily by the Chinese government during SARS. There were something like 20,000 people in Beijing who went into quarantine in these big sort of tents that were set up. The problem with quarantine is that people in quarantine, if somebody actually is going to is infectious, it's going to spread around to everybody else. But that didn't happen in Beijing. That was at least the experience. So isolation is for people who are symptomatic, in this case symptomatic. It's for people who are infectious. And quarantine is for people who've been exposed but are not yet infectious. Okay? So, so you want to do, so you need to have these sort of in-between units where people can be evaluated and held until a definitive diagnosis is made, okay? And then in addition, you want to do contact tracing and monitoring of all confirmed cases, contacts for 21 days. And for anybody who came to the, or watched the town hall last Thursday, the Chancellor's town hall about Ebola response here, people who'd come back had lots of pictures of going around and doing contact tracing, going out with the Ministry of Health teams to check on people. And all you basically have to do is take the temperature, right? And this is not glass thermometers. These are these things you can hold from this far away and take their temperatures. So, but in order to have an effective response, people have to come in for care, right? And so the more you sort of take their relatives and they never see them again and they're whisked off, the less likely they are to fork over the next set of relatives. And so that's a real problem. There's been a lot of distrust because people just sort of disappear off into Ebola land. But you need to have supportive care for patients. You need to have isolation of contacts as soon as they become febrile. And then there needs to be a lot of social mobilization around this. The primary preventive prevention focuses around meticulous infection control in the hospitals, so where transmission is most likely, which includes barrier precautions, but respiratory precautions are unnecessary. Now, we in the United States, including this institution, have elected to have respiratory precautions because for sort of a practical reason, that in certain circumstances, like you're going to do endotracheal lavage or suctioning or something like that, where you could create an aerosol, you probably do need respiratory precautions. But, you know, and so rather than saying, oh, I got to go out of the room and put on respiratory cautions and come back and do this procedure, they just say, just do it all the time, right? So that's, for any of you who've been trained or have gone and seen the training at Mount Zion, we use respiratory precautions, but it's for a very practical reason. It's not because there's respiratory spread. Obviously changing funeral practices, and then the kind of the primary prevention message here is avoiding bushmeat. Now, how many of you have worn this PPE stuff? Anybody? Yeah, okay. So would you describe this as comfortable or uncomfortable? Okay. Uncomfortable. Imagine doing it in the tropics, right, with no AC, right? This is a great editorial that a nurse wrote who'd been with MSF. No one should wear the PPE for longer than 40 minutes. It's unbearable for any longer than that, but it's easy to lose track of time, so we have to monitor our colleagues. The process starts in the dressing room, where getting into PPE takes about 5 minutes. We have a designated dresser. I love this, just like in Broadway, right? Responsible solely for making sure that we are wearing our equipment properly and that not a square inch of skin is exposed. In case one layer is accidentally perforated, we wear 2 pairs of gloves, 2 masks, and a heavy apron. When they first started to do this, the materials were permeable. So they had to start putting these big rubber aprons on. On top of full body overalls. When we exit the isolation area, we're sprayed down with chlorine and peel off the PPE layer by layer. Some of the equipment, goggles, apron, boots, thick gloves, can be sterilized and used again. Everything else, overalls, masks, head covers, is burned. So the basic...
In Africa.
This is in Africa. Right. Here we give it to somebody who takes it off and burns it, and we pretend they're not burned, but they are. They're sterilized, you know. And they're sterilized when they take them out. The sterile material's out there, ash, but you know. And I'll talk about Emory's experience with rubbish, with kind of hauling medical waste away. So, you know, this is just general outbreak containment strategies. You want to have public information and education. Here you want to encourage patients to come to isolation facilities where they can be diagnosed and triaged. There's a lot about basic hygiene and hand washing and avoidance of traditional burial practices. As it gets worse, there are all these euphemisms. These are all great CDC euphemisms. Focused measures to increase social distance, right? So what does that mean to you? You're an oldest child sitting up in the front. Yeah.
Stay at home.
Yeah, okay. So yeah, work from home, stay at home. Don't get on Muni. Close Muni down. Speaking of breeders of disease. Actually, what this really means is staying at home, staying away. Then there are community-wide measures to increase social distancing. There's a great description from St. Louis in the 1918-1990 influenza pandemic, where they tried to do this exact thing, and actually quite successfully. And they did stuff like they closed movie theaters and dance halls and pool halls and, you know, all this stuff like, you know, what? You know? But it was basically the kind of the movies of the time, the malls of the time. Those all got closed down, and they closed the transportation system. When you close the transportation system, things stop. Transmission really stops. And then kind of at the final layer is something called a cordon sanitaire, which is where you draw a line around an area in which transmission is ongoing and you don't let anybody in or out. So did you ever see this stupid Dustin Hoffman movie called Outbreak? Yeah? Where they, you know where that was? So you saw it? Yeah. So what saved the world there?
Wait, I always get this one confused with the other one, the hotspot.
Yeah, with the Rene Rousseau. Yeah. That's what everybody says. Well, what was EIS like? I said, well, I was like Rene Rousseau, but I looked better at the end of the movie because she was dead. But, you know.
I remember correctly, wasn't it a monkey?
Yeah. So they have like a monkey like this, and they get enough immune serum out of the monkey to save 500 people, you know, in like 10 hours, right? You think a cardiogenic shock might come in at some point in time for the monkey? But you know where that city was? That town they used? It was Ferndale, which is the first town as you go up 101 and you cross into Mendocino County. So that was the one the Army wanted to bomb, you know, the bad guys. For those of you who had no idea what we're talking about, this is a it's a trip down memory lane. Donald Sutherland, Dustin Hoffman, Patrick Dempsey, yeah, all in Outbreak, right? That's what it's called. Yeah. Anyways, that's when you draw a circle around stuff, and typically, at least the plans here would have to take the National Guard. And there are actually real plans in China around new influenza outbreaks where they do involve cordon sanitaire. Okay, so there are a whole bunch of issues, as you can imagine, trying to get all the population on the same page here. There's tons of human resources needs. There's a big deal about security. These are basically unsecured situations. They're like refugee camps, right? You need access to labs so you can actually diagnose people, and they're not. And people who are uninfected aren't sitting in these quarantine facilities forever waiting for their tests to get back. At some point in time during these things, the turnaround time was around 3 days to get the results back. So that's not where you want to be sitting. Having enough stuff, having social mobilization and community engagement. Transportation issues here were unbelievable. Went through one rainy season where the roads basically shut down. And when MSF, the Médecines Sans Frontières, in August called for military intervention, which is the first time they've ever done that. This is exactly what they were talking about. People need things like vehicles that can go through mud. They need helicopters. They need logistics. They need people who will do what they're told and can act as sort of in concert. And I think that was probably the right move. And you see in Liberia where that really happened, where the U.S. committed. So, so Liberia is the U.S., Sierra Leone's British, and Guinea's French. And where the U.S. basically brought an aircraft carrier in and flew supplies back and forth and really set this stuff up. Things are going down in Liberia. You need, there's a lot of research and product development that needs to go on. There's a lot of money that needs to come in, and there needs to be a lot of coordination. So just to give you an idea of some of the responses, Sierra Leone in September ordered a 3-day shelter in place and sent people around to count cases to identify sick patients. So rather than leaving it to passive surveillance for people to come in, they went out and found everybody. They had huge information and education campaigns. If you can't get to an ETU or to one of these sort of intermediate sites, stay at home, isolate yourself at home. And then one of the more interesting things was that at least in Freetown in Sierra Leone, they treated everybody for malaria. They did MDA's mass drug administration for malaria, basically just to sort out, get rid of all those fevers, the malaria fevers, so that they could say who is more likely to have Ebola and who's not, which I thought was kind of an interesting idea. And then the contract tracing and monitoring. So in terms of organization, there are Ebola care units, which are these smaller things. They have different names. They usually take care of 8 to 10 patients, but they're not full ICUs. They don't do parenteral therapy at all, so there are no IVs. They're the big Ebola treatment units, which are much more concentrated, and that's like an ICU. There's home-based isolation that MSF has offered, basically giving home supplies, which are like gloves and plastic sheeting and stuff. So to try and isolate people at home if there's no room at the inn, and there's been lots of examples of people dying waiting to get into an ETU. And so this is not something you want to do, but it's a desperation move. The CDC and the US military and the Europeans have really pushed and brought in a lot of additional healthcare workers. And then the interesting thing is that there's starting to be a role now for people who've recovered and using them not so much for home isolation, which is when I made this slide, but for the Ebola care units, these sort of step-down units. So you take people who are immune, right? You get lifelong immunity if you've been infected. Once they recover their strength, and these people are very frail when they come out of this, and you use them to staff the Ebola care units and to be orderlies in the treatment units and stuff, because they really are, they really are immune. This just gives you an idea of what one of these looks like. This is in Guécadou where the epidemic probably first started. These are very much jerry-rigged. This gives you an idea of kind of how this works. So there are all these sort of support things over here. And there's a staff entrance, right? And then there are wards in here. There's a triage tent for people who appear at the edge, and you're trying to sort out whether they're infected or not. And then there are obviously sort of big morgues and treatment wards here. So it's, and there's a perimeter set up here. I don't know if you can see it, kind of a plastic fencing perimeter. So people who are uninfected on this side, this is sort of the clean side, the dirty side, or the green side and the red side, they can talk to their relatives across the fence. Because once these people, remember, 50% of people recover, or 60% of people recover. So, they're out regaining their strength. They want to talk to their relatives. This gives you an idea of where they're located. There's weekly WHO situation reports that update these maps, but you can see how they really haven't spread very much in Guinea, except down here, kind of where all the action is. And there's not that great coverage in Sierra Leone. And this is what the aprons look like. Right? This gives you an idea. This is one of these middle-sized units, and this is in Bomi County in Liberia. And this is this sort of Ebola care unit or community care center. These are smaller again. This is their result is, their role is to isolate patients who are awaiting results of diagnostic testing. But they also are holding places for people with confirmed disease until they can be moved to the ETUs. Again, transportation is complicated. And they also have they'll also hold people who they think by symptoms probably have the disease. So if they're vomiting blood or something, they'll hold them there. They separate the people who are being isolated from the people who are awaiting transport into 2 wards, but the management is minimally invasive. ORS is oral rehydration solution, so they try and keep them hydrated orally, and doesn't go very well. So if you get Ebola, you want to get to one of the big Ebola treatment units as quickly as possible. Okay. Now, this is a good story. This was the largest, that's the Atlantic Ocean out there. This is the largest, Ebola treatment unit that was built. It has 360 beds, the ELWA 3. This is near Monrovia. And you can get a feel for just the massive undertaking that this is. As of last Wednesday, this facility did not have a single patient, right? So that gives you an idea of kind of the progress that's being made in Liberia, and they're starting to decommission these facilities. Unfortunately, they're so contaminated that they're burning them, so they don't get any kind of infrastructure out the back end. But they'll decommission them sort of piece by kind of unit by unit by unit, but they basically burn them, and that's just part of the deal.
So I thought fomite transmission was not part of this, though.
It can be, but how long it survives, you have to be pretty brave, right?
Can you repeat the question?
I'm sorry, the question was she thought fomite transmission wasn't part of the deal here. There probably is some fomite transmission, but not very much. But you'd have to be pretty brave to
reuse this stuff.
Yeah, to basically to reuse a facility where you've been dumping blood from infectious patients. So what's happened in the U.S.? I think we touched on this. There's 6 healthcare workers have been evacuated from West Africa. 5 were treated successfully and 1 died. There are actually 7 with 2 deaths now. There was a traveler from Liberia who was asymptomatic, was admitted to a Dallas hospital and died. He actually got discharged from the ED and had to come back 2 days later. And a physician who was isolated in New York. There were 2 healthcare workers in Dallas who developed disease, mild disease, and seroconverted, were successfully treated. This coming back, have any of you gone and come back from West Africa? I don't recognize anybody. I have to personally prove it also. It's coming back is kind of crazy, actually. Everybody's routed through one of 5 airports, which are Kennedy, Newark. That's just how Governor Christie got his nose into it. Atlanta, Chicago, and Dulles. And so they come in and they get screened. So you get screened if you're trying to leave. So somebody's standing out there with a thermometer, and if you have a fever, they don't let you get on the airplane. If you don't, then you get on the airplane. Most of these flights go to Brussels, by the way. You get on the plane, and then you're met on the other side, and you get your temperature taken again. If you're febrile, you get pulled off. If you're not, you're allowed to go on. Then you come to the U.S. And when you come to the U.S., the CDC people meet you and, basically go over your story very carefully. And you're examined, and you have your temperature taken. And then you're allowed to go on, but you have to make contact with the local health department in your jurisdiction. CDC forewarns them. So here in San Francisco Department of Public Health, there's a program, and basically people are visited daily. So for this 21 days, if they've had patient contact, it doesn't matter if they have patient contact or not. So for 21 days, they are seen by someone from the health department in their houses, right? And they have their temperature taken, and then they have to report in their temperature at 12 hours later. So they're basically at 2 data points for each day. And then they're, at the end of 21 days, they can be discharged. These are all done under health officers' orders. Since this is kind of a public health class, local health officers in California are the ones who have legal authority to quarantine people. So this is quarantine. If they became uninfected, if they became symptomatic, they get pulled out and sent over to Zion, at least here. There are different degrees of risk. So if someone had a known needle stick exposure, for instance, or a sharps exposure, they probably wouldn't be let out of the country. They'd have to do their quarantine there. If they had direct patient care with like regular PPE, they're considered at some risk. And at least here, we tell people, the health officer's orders say they cannot return to work, they have to remain in their residence, and they have to have a 3-foot, which is a rough translation of a meter, separation from other people. So we've had one of the ICU attendings went, and basically he came back and his family moved in with his relatives until the 3 weeks were up. Right? If you have low risk, which means that you haven't had patient contact, but you've been leading training or doing public healthy kinds of things, you actually can return to work. So we have several people in our group who've gone and come back and basically just have to send in their temperatures a couple of times a day for 21 days. So it depends on where you were, what you were doing. This is just giving you a little bit more. There are about 100 people who come back to the U.S. each day from these countries, just to give you an idea. So Emory, who had the first patient that came back, and I was actually at CDC that day. I've never seen so many news vans in my life, parked along Clifton Road. The Emory experience, and there were a couple of patients that came back initially, was that these patients were leaked like crazy. They were profoundly hypovolemic, at least, based on CV, central venous pressures and stuff. But they had massive, but they had big weight gains too, because it's all extravasated fluid, and they were estimating the fluid losses at between 5 and 10 liters a day. A normal adult would need about 2 liters a day to keep the tank full. They had all sorts of problems with electrolytes. They had arrhythmias, which are probably secondary to the electrolyte disturbances. They became nutritionally depleted just because of the nature of the disease. They had RNA detected in blood, urine, vomitus, stool, endotracheal sections, semen, and skin. People sweat with this disease, and it's in sweat too. But the environmental testing never was able to recover RNA in the room, including things like bed rails and stuff like that, right? They're tested a lot. So they did intensive 1-to-1 nursing. They now do the recommendation now is for 2-to-1 nursing, so 2 nurses per patient. And because they didn't want to send specimens around, they set up a point-of-care testing laboratory next door in the next room over. They had sorry, let's see, did I miss one? So commercial carriers refused to transport the specimens, interestingly. So FedEx was saying, we're not doing this. But the nice thing about Emory, have anybody been to Emory Hospital? Yeah. So, CDC's on the Emory campus, right? So they just walked it across the parking lot. So, if I'm at the Emory Hospital, CDC's like where Millbury is, right? So they walked it across. There was all sorts of issues around regulatory stuff, like OSHA gets involved and sticks their nose in it, and there are all sorts of jurisdictional issues. They did use PAPRs, the purified air, personal air purified respirators, the kind of respiratory precaution things, just because they thought it was simpler to do that rather than to have to make decisions about yes or no. They always had a dresser there. They disinfected all the liquid waste with bleach or detergents and for 5 minutes, and then before they could flush it down the toilet. They autoclaved all the waste for it to be acceptable for disposal as regulated medical waste. They actually filled up 4 cargo containers full of waste. Just the amount of stuff that this generated. There are all sorts of issues around communications, both internal and external. So if you think about Emory and you think about us and you think about altruism, there are kind of 2 different things that you have to deal with. One is that you have to deal with your own medical center. You have to have policies in place for screening patients coming into the EDs and into the clinics and being admitted. And so that's one whole thing. How do you deal with patients, right? And here we have, I think as you've probably are aware of, we have elaborate policies in place for asking everybody, have they been to West Africa in the last 3 weeks? This is always sort of a big geography lesson for people. And are they febrile, right? And if they are, they go in door A, and if they're not, they get into regular care. And then we have these elaborate protocols about moving patients to the biocontainment unit which is now in the old ICU at Mount Zion. There are 2 beds there with a lot of training that has gone on of people who will actually provide direct care for patients if they were to appear. So that's the kind of hospital part of it, and with lots of press office involvement and pre-prepared press releases, and you can only imagine, right? The other thing is that we're at a very altruistic institution, and as opposed to many other institutions which basically have said, if you go to West Africa, you're on your own, we've tried to remove barriers for people who want to go, who can go, who want to go, so that they're able to go. And we've had lots of, I don't know how many of you know these things, but have been exposed to this stuff, but Stanford, where I was an undergraduate, which I love dearly, basically said, the dean said, if you go to West Africa, you don't have any insurance, you don't have any evacuation insurance, we're not sure you're going to have a job if you come back, right? Pretty harsh. What we've said is, if you go to West Africa, we just want to make sure everything's be okay. We want you to do the CDC training. We want to have a checklist. We want you to keep track of who you see. So we have people actually keep diaries of patient care. So that helps on quarantine on the other end. We have a emergency vacation leave donation policy, so people don't have to use their own vacation. And there have been about 2,100 hours donated. And we have a very much of a kind of fast throughput occupational health program that will screen people prepare people to go, and screen them when they come home. Remember, these are malarious areas, so they have to take, and there's yellow fever, so you have to have vaccines, you have to have malaria prophylaxis. There's lots of other stuff you need to have. So I think we've done pretty well compared to other institutions. UCLA really hasn't done much. I should just add. Actually, the other people, Kaiser's done is remarkably similar things to what we've done. So there are all these issues about return to work, administrative procedures and stuff. So the other thing we do as a university is research. And there have been a couple of investigators, Charlie Chu in lab medicine has done a lot with diagnostics. Our group has done a lot with surveillance and kind of response and epidemiologic questions. We thought we'd be more involved in clinical trials. Those have kind of gone off on a different direction. And then the other thing we've done is fundraising, and the Benioffs have been very generous in supporting some of the response here. There's also been some crowdsourced funding for, specifically for Sierra Leone, where we have some traditional ties. So what can you do? You can assure your hospital's prepared. I think we've taken care of that. There's continued need for healthcare workers in West Africa. If any of you are wondering how you want to spend your summer, especially in Sierra Leone, there's continuous need for PPE and disposable medical supplies. There's a remarkable charity, which I can't remember the name of course, but I met with their CEO, that basically puts cargo containers full of stuff together. And they have one going to West Africa that's taken a lot of the kind of supplies from here and from other institutions as they outdate or as they get close to outdating and move them off. The other thing is these countries are devastated by this. There will be, and so Liberia and Sierra Leone are coming on top of 10 years of civil war. The infrastructure, and not just the health infrastructure, the educational infrastructure, agricultural infrastructure are all devastated. And so these are going to be long-term aid problems over the years. And this is, if you want to get CDC training, this is what you want to do. That's where you go get it. And it's free once you get to Anniston, Alabama, which will, I think that's where the Dukes of Hazzard was filmed, so just so you're prepared. And USAID set up a site to triage healthcare workers who are interested to International Rescue Corps, Partners in Health, Médecines Sans Frontières, the big organizations. But that's what's cooking. And this is our crowdsourced funding site. So I'll stop there and answer questions, 20 after. Please.
As far as like mobilizing the community around containing Ebola, my understanding was that there was a lot of resistance in the beginning, people not believing that Ebola was real.
Right.
And do you know, like, what was the source of that? How did that come about? What was the...
People don't want to believe stuff, right? It's, it's like, why don't people vaccinate their children in Marin County? I mean, there are obviously weird theories that circulated. But, basically, people would come in dressed up in these suits, take their relatives away, and they'd never see them again. And they wouldn't get to bury them, which is a big deal. And, so there's just resistance to this stuff happening. And so there had to be a lot of real serious kind of engagement through the traditional tribal structures and through the more governmental structures. Government sort of doesn't really exist out in the sticks because of the civil wars. So it really has to go through the traditional tribal structure. So there's a lot of convincing that has to go on. And rumor control is a big part of outbreaks, right? So your perception is completely correct. And there have been places where healthcare workers have been chased away as they come into a village with sticks and stones. And it's, you can imagine how disruptive this is. Imagine this happening in San Francisco and a bunch of people coming in from Nigeria telling you what to do, right? It's the same thing.
And on the flip side, once people did believe, and were on board with what was going on.
Yeah.
How was this stigma in terms of like people that were treated and survived and then they would be released back out into the community? What sort of stigma was around that and how were they accepted?
They don't want anything to do with them.
Even with their own families?
Yeah, it's highly stigmatized, and that's the new campaigns. But because we want to give them jobs, all of a sudden they're wage earners, and because we want to use them in these care centers, right? So that kind of is that's the sort of counterbalance to some of that. But yeah, it's been a real problem, Yeah, good, please. Yes.
So, people in Africa, probably they have been living and eating, the practice of barriers for eating for a long time.
Yeah.
Right? And now, why it becomes such a global issue?
So why was this different than what happened in the Congo, for instance? So Why is this different? What's different about West Africa versus Central Africa?
My understanding is because of the transportation, probably in the past, the transportation is so isolated.
Yeah.
Now it's become like a global transportation.
Right.
causes.
Yeah. Well, it's actually transportation is probably somewhat more. So did everybody hear the question? It's like, why is this one different than the ones in the Congos with 300 cases and they burn out? Actually, if you look at, let me go back. Let me show you something. It's kind of interesting. Don't look at this if you're just eating breakfast. So look here if you look at Uganda here, so in the 2000s there were 425 cases, and in the mid-2000s there were 139, and the last time there were 15, right? So they get better at it, right? They get better at response, they get better at recognition, they get better at containment. So part of the thing is that no one had seen this before. Now there was some Lassa fever that was kind of way up in the corner of Guinea, near the Malian border, and that was why Institut Pasteur had a laboratory there. But it wasn't to look for this hemorrhagic fever virus, it was to look for another. But basically these countries had no familiarity with this at all. So that's one problem. So it's somewhat slow to respond. A second problem is that the transportation systems, as you point out, are not very good. They're actually probably better in Zaire, where the people move by river. So it's a real kind of a riverine transportation system. But what's really different about this is that it got into big cities. This has never been in a big city before. These are all kind of rural, isolated places, I mean, with the exception of a handful of laboratory accidents. And it's, that's what you see. You see urban epidemic spread. And that's what's really different about this. The other thing is that if I was at the conference on retroviruses and opportunistic infections last week, which is the big AIDS conference, one of the big AIDS conferences, but they've somehow sort of slopped over into hepatitis C, and now they're doing a little Ebola stuff. And there was a guy from Médecines Sans Frontières who did a presentation, and they juxtaposed their communications with WHO communications. So, they were calling for massive WHO intervention in April. The Director General says this appears to be a relatively isolated problem. It kind of was this back and forth. And it really took into August to make this happen. And that was when MSF said, we need military involvement. We need military intervention to keep this under control, which is what happened, right? So I'd say unfamiliarity with the diseases, the fact that it got into urban environments, and a very slow international response. And actually, there's some real serious consideration going on now at WHO to have essentially like a GO team or something, whatever you want to call it, basically to investigate and try and control outbreaks that's pan-African. Now, getting everybody to agree to this is going to be complicated, but they kind of finally put one in for the EU, which is based in Stockholm, the European CDC. And there's a similar kind of thing, that the Pan American Health Organization has done for Latin America. So there's some thought that they might be able to do something for Africa, to have like an African CDC. And I'm cringing that they're going to call it ACDC, but
I would love for you to comment on the nurses who were infected here at the Dallas hospital.
Yeah.
And that was the end of September.
Right.
And I guess the patient died, I think October 9th, I think he died. I can't quite remember.
Something like that, yeah.
But, overuse of PPE was thought to contribute. There was some skin exposed. I mean, why did those 2 ICU nurses get infected?
Well, so did everybody hear the question? The question was, so what went wrong in Dallas? Why did the 2 ICU nurses get infected? There was a strategic decision there was a strategically very poor decision that was made at CDC, which is that all hospitals should be able to handle these patients, which was, I think, in retrospect, even at the time, was completely the wrong decision. There's too much ramp up on training. People are unfamiliar with this stuff. There are a million mistakes that can be made. I don't know if you know this, but before Ebola, there were 4 biocontainment units in the United States, like just exactly what you need. Emory had one. The clinical center at NIH has one. There's one, for unknown reasons at the University of Nebraska. And even for more obscure reasons, there's one in, it's like someplace in Montana. The one in someplace, it's in Missoula, Montana or someplace. The one in Montana is because that's where the NIH's Rocky Mountain Laboratory is that does all the rickettsial research. So that's okay, that one kind of makes sense. But the reason you see these people go into these places is because they're the ones who've had these things set up since the anthrax outbreaks in 2001. So there was a decision made by the director of CDC that everybody had to be prepared for this. Now, I completely agree that all the emergency departments and all the clinics have to be prepared, and they have to be able to hold these patients for a few days until they can move them. But to try and do this kind of complicated care in this stuff is burden. This equipment's not easy to move in, right? So when I was a resident, we started IVs with no gloves all the time, right? And so I find it hard to start IVs with gloves on. So you can imagine, having like kitchen gloves, It's just too complicated. And, they were insufficiently trained and insufficiently experienced. But it was a structural problem that led that. There's no way you could train people in that amount of time sufficiently to be, to really protect themselves.
Has the CDC changed their tune?
Yeah, that's why they're doing this licensing thing. So, not licensing, they're doing certification. So, we have a certified unit. Kaiser Oakland has a certified unit. Davis has all the UC hospitals are certified, and Kaiser Oakland and Kaiser South Sacramento. Yeah, please.
Weren't they also unprepared for the volumes of biohazard waste?
It's, as I said, at Emory, these 2 patients generated 4 cargo containers worth of waste. It's just unreal. And then all the people in the waste stream and kind of water disposal stuff get into the act, and they're making up their own rules, and then OSHA comes along, which never met a problem it didn't want to regulate to death. And, it just gets, there's like lots of cooks in the batter. Yeah, please.
Has UC changed its policy on trainees going?
Oh, that's my policy. Sort of. I don't see there's any reason to have a 3rd-year ICU fellow not go, right? So we have, right now, there's a 3rd-year hospital medicine fellow who's going, who's in her 7th year of postgraduate training, because you did med peds, and there's an emergency department attending there. So we've relaxed. There have been 3 or 4 exceptions, granted, but basically the idea is we didn't want first-year medical students going there this summer. And then it gets sort of multiplied up through the ranks. And for nurses, it's crazy. Because you guys, so if somebody's in the what's that thing called?
MEPN.
No, not MEPN. I got that straight. No, the one that does like health policy and health management.
Right.
Yeah.
Health policy specialty.
Yeah, the health policy, that master's degree at Laurel Heights, right? If you're in that and you've been an ICU nurse for 12 years, who cares, right? That doesn't change your status. The concern is we don't want a lot of clinical learners there who aren't really up to speed. So one of the fellows, one of the global health fellows who went, who's a nurse, is an ICU nurse at Stanford. Okay, so pretty easy, right? That's a pretty easy call. But, the idea is we didn't want a bunch of like early learners going. Yeah, Raj?
You mentioned.
Sorry, peach, salmon, whatever color that is. Yeah.
Salmon-ish. You had mentioned that the health systems in these countries were already sort of operating in a deficit before this hit. So when Ebola hit, that just sort of devastated a lot of the capacity already.
Yeah.
So now, a year plus into this, what signs have you seen, if any, in any of these countries where you've seen some, maybe like an untoward effect, that because there's been a lot of money and resources put into trying to set up systems to deal with Ebola, has that spilled over into the general health system?
Yeah, so that's a great question. The question is how much spillover benefit is there to the rest of the health system? And the answer is largely none. Because these things are so specialized, you know, and the patients are so infectious, right? You know, you don't want to be, you know, delivering babies in the, you know, dealing with obstructed labor in the OR in an Ebola treatment unit, right? So there has been some training, substantial training of healthcare workers, local healthcare workers who will still be there at the end of this, but the facilities part still is going to lag behind because, as I said, as they decommission these places, they burn them. So there's no bricks and mortar. I mean, none of this was bricks and mortar to start with, it's just tents, right?
I mean, I was struck by, you know, the map of when you showed the schematic of that one treatment unit, and there's a water tank there.
Yeah.
Meanwhile, down the road, there's probably a government clinic that doesn't have any water or electricity.
Yeah. It's a real conundrum.
Couple more questions?
Back, yeah. Yep, please.
Yeah, I'm just really curious about, you know, establishing these centers of excellence where they, you know how to treat, et cetera, et cetera. I think is fabulous. I guess my question is, you mentioned transportation.
Right.
And, you know, I'm just wondering how, you know, if that's being considered in the equation that, you know, if you have to transport, say, somebody from San Jose to UCSF.
Yeah.
Is that, there's a trickle-down effect in terms of they'd be transferred, I mean, I'm just kind
Right.
of laying it out. Say they'd be transferred by an ambulance. Are
Right.
those paramedics, et cetera, also, you know, it seems to me like they should have some sort of.
Yep, they are. They're all part of the equation. And a lot of this is air transport too, so all those air crews are part of the transportation as well.
Oh, only air.
Because if you want to move to, you know, Missoula, Montana, wherever it is, you know, you don't get in an ambulance and go from here. Right? Yeah.
So maybe I'm a little naive here, but I seem to recall that those that survived Ebola here in the United States, their blood was used to help the others that got infected. What's happening in West Africa? Is the same treatment occurring? Are we going to the survivors of Ebola and working with their serology to try to develop something for the people to circumvent the
Right.
spread?
So you're completely correct. I might dispute the word help. They gave it to them. Whether it helped or not is anybody's guess, right? Because it wasn't done in any kind of controlled way, and you know, so like nobody knows. So there's some of that that's going on in West Africa. There is a special treatment unit in Monrovia for healthcare workers that got infected, and again, this is kind of an occupational safety thing. You want to show that you have a commitment to healthcare workers, so if they do get infected, they're going to go to the really good place, right? It gets into sort of tiers of service, as you can imagine. And there they do harvest antibody. The blood banking system in these places is not sophisticated. And, you know, being able to bank and, you know, the plasmapheresis and bank and store serum is complicated. And it's just something that's not going to be able to be done on an industrial scale. That's why, like, monoclonal antibodies, like with ZMapp, if they could harvest, make it, you know, get enough of it quickly, that's the same idea, right? They get enough of it quickly. That's why that's going to be a better product than waiting for immune serum globulin.
I'm curious if there's any sort of thinking. You mentioned that there's sort of a fallout of like hospital closures, and I've heard sort of anecdotally that that there is sort of significant reductions in vaccine rates and other like sort of addressing other healthcare issues that were already endemic.
Yeah.
In these areas before Ebola became sort of the center of attention. I'm wondering if any of the funding that's going into Ebola is going for supportive services to address some of those other endemic issues as they become worse because of the Ebola attention.
You'd like to think so. I mean, I just don't know. You're completely correct. Actually, there was a presentation last week at CROI, this conference, that looked at AIDS patients starting ART, and you can see a real dip when the system was maxed out. It looked like it recovered, though, and I think in the next round of vaccine coverage assessments, we'll know kind of what the problem is, how big a problem it is. Yes, you would like to think that they're doing replacing the primary healthcare system as they went along. So these hospitals are actually coming back online now that they don't have to worry about it so much. A lot of them were taken offline because of concerns about nosocomial transmission. It wasn't so much that, it was just that they said, we can't protect our staffs. We have no idea what we're doing. We can't do it.
I have two closing questions. I just wanted, Caitlin, why don't you ask yours?
Your map where you showed, it looked like there was nothing in Cote d'Ivoire and Mali.
Right.
How was that a cordon sanitaire, or how was that, how did it not go into Cote d'Ivoire?
It didn't. Well, first of all, there wasn't a lot in the southern part of Sierra Leone. I mean, in Liberia, right? Now, yeah, they screened at the border. It was essentially a cordon sanitaire. I mean, nobody used that term, but that's essentially what it was. That they were trying to cut down on transportation across the borders. In Mali, there were cases. There were 8 cases in Mali. And there was people who gotten on a bus when they were asymptomatic and made it to Bamako, the capital. Bamako's about here, it's like up there. They became symptomatic there. But they really clamped down tightly on the borders. And the amazing thing is done in Guinea-Bissau. I would have thought that this thing would be completely filled up, but it's just not.
Great. And so I wanted to just ask a question. California, as you may or may not know, has the aerosolized transmissible disease standard. It's an OSHA standard, Cal-OSHA standard, not other states. No other state, I think, has an ATD standard. And so from an occupational health perspective, we perceive, even though Ebola is not transmitted in an aerosolized, droplets, aerosols, we get into this debate all the time, but primarily not respiratory. People thought that California was better positioned to sort of respond to this disaster because nurses and healthcare workers were already respiratory protected trained. What are your perspectives on that? Do you agree or disagree?
Well, the proof's in the pudding, right? There have been 0 cases and 0 transmissions and 0 deaths. So,
right.
I mean, I think the 0 cases are probably the most important part of that equation. But yeah, I mean, I think, sort of it makes sense that people who are better prepared to deal with all this stuff, and it's not just the PAPRs, but it's all the other accoutrements, are going to do better in infection control prevention. But just have to realize at the end of the day, despite there being 9 patients here, there have only been 2 transmissions, right? And
And then I just wanted your closing comments on vaccines, actually just vaccines as a primary prevention measure, as you brought up, but also just how about hand washing?
Important.
Really? I mean, that was one of the key messages.
So the way they said it was, wash your hands as if your life depended on it, because it does.
Right.
And a lot of the sort of exposure that goes on is when people's taking this stuff off. So you can't shoot your gloves at your friends and stuff. It's taking all this stuff off where you get the exposures, and you got to be really careful when you take it off. It's much more important than when you put it on.
So soap and water kills this virus. All right, thank you so much.
My pleasure.